A very good morning to all of you. Respected invited guest speakers, Dr. Ilsa Varghese ma'am, Dr. H.M. Krishna sir, ISA NCB President Dr. Saurabh Burde, Head of the Department of Anesthesiology, NKP Salve Institute of Medical Sciences, Dr. Anjali Bhure ma'am, and all dignitaries attending the online CME. I extend a warm welcome to all of you to today's CME on anesthesia for laparoscopic surgeries. This CME is being organized by Indian Society of Anesthesiologists Nagpur City Branch in association with Department of Anesthesiology, NKP Salve Institute of Medical Sciences and Research Center, and Lata Mangeshkar Hospital, Nagpur. We all know that presently laparoscopic surgery has gained wider application due to the advantages and has become the gold standard in many fields like gynecological surgery, urology, gastrointestinal surgery, especially cholecystectomy, appendectomy, etc. In high-risk patients with significant pre-existing pathologies, understanding the physiological consequences of capnoperitoneum is paramount, especially in patients with cardiac anomalies, the morbidly obese patients, in poor respiratory reserve patients, pregnancy, patients with liver disease, elderly patients, etc. Not only in adults, but in pediatric patients also, laparoscopy has become very popular. Pediatric anesthesia is in itself a challenge, and the effect of pneumoperitoneum created and the extreme positions that is required for laparoscopic surgery, it poses special problems in this age group of patients. So today we will know from our distinguished speakers how to make laparoscopic surgery safe in high-risk patients and in the pediatric patients. So before we start, let me invite Dr. Saurabh Burde, President of ISA NCB, to welcome everyone.
Thank you, Gauri. Good morning, respected seniors, teachers, and dear friends. It is my great privilege to welcome you all on behalf of ISA Nagpur City Branch for today's academic activity. Being minimal invasive surgery, the patients are more than willing to go for newer and newer laparoscopic procedures, not only in adults, but in pediatric population also. So I remember one case of congenital tracheoesophageal fistula with proximal segment connected and blind distal end. The patient had undergone primary disconnection of fistula and feeding gastrostomy at birth, and now the patient was for esophageal reconstruction at 3 years of age. So we routinely do these procedures without laparoscopy. So sometime before lockdown happened, a surgeon from USA had been to Nagpur and joined our routine surgeon for laparoscopic technique of mobilization of stomach. This was the first time for me involving laparoscopy for this procedure. 30 minutes into laparoscopy, patient started desaturating with SpO2 going below 90% in spite of FiO2 of 100%. And airway pressure slowly rising with difficulty in ventilation. I asked them to stop the laparoscopy and CO2 insufflation. It took almost 5 minutes for SpO2 to come back to 100%. We waited for 15 more minutes to confirm everything remained stable. Again, they resumed, and within 15 minutes, same thing happened. I again asked them to stop everything and also noticed subcutaneous emphysema in left side of chest extending into the neck up to mandible. I asked them to abandon laparoscopy. The surgical emphysema decreased after some time, but did not resolve completely till the surgery was over. We discussed amongst us but about continuation and later continued the procedure with a routine conventional non-laparoscopic technique once patient was stable as far as airway pressure and oxygenation was concerned. But I did not have the courage to extubate the patient on table, which we routinely do in almost all patients. Later, the patient was extubated in pediatric ICU, 6 hours post-op after complete resolution of surgical emphysema. So most of us routinely administer anesthesia and laparoscopic surgical procedures in patients of all ages and also who may be having complex comorbidities. When a proposal came from Dr. Anjali Bhure Madam, Professor and Head Department of Anesthesia, NKP SIMS Nagpur, about the possibility of academic activity with ISA Nagpur City Branch, I discussed this topic with her and she agreed upon this. My sincere and special welcome to today's esteemed faculty, Dr. Ilsa Varghese ma'am, Professor and President Indian Society of Pediatric Anesthesiologists, and Dr. H.M. Krishna sir, Professor and Head Department of Kasturba Medical College, Manipal, who will enlighten us on the intricacies of anesthesia techniques in special population patients. So without wasting much time, I hand over the proceedings to Dr. Gauri. Happy listening. Long live, I say. Thank you.
Thank you, Dr. Saurabh. Now I invite Dr. Anjali Bhure ma'am to address the dignitaries.
Good morning, all. A warm welcome to our esteemed faculties, Dr. Elsa ma'am and Dr. Krishna sir, and all our dear members. Laparoscopy is close to every anesthesiologist's heart, but at some given point of care, we think something needs to be known more. And hence this everyday affair of laparoscopy was chosen as a topic for today's discussion. I thank Elsa ma'am and Krishna sir for spending their valuable time with us to enlighten on this topic called laparoscopy. Thank you. Over to Gauri.
Unmute Gauri yourself.
Thank you, Bhure ma'am. So we move on with our first topic, anesthesia considerations in pediatric laparoscopy. It's my proud privilege to introduce our today's guest speaker, Dr. Elsa Varghese ma'am. Ma'am is a former professor and head of the Department of Anesthesiology, Kasturba Medical College, Manipal. She's former senior consultant anesthesiologist at MIOT International Hospital, Chennai. Madam has been invited for over 100 lectures as speakers at various national and international conferences. Especially to mention, she was invited as speaker in the 15th World Congress of Anesthesiologists. She has delivered many orations, like Dr. P.N. Thota oration in 2014, Manipal, Dr. Francis oration by ISA Kerala State Conference, in ISS Kerala State Conference in 2013. She is president of Indian Society of Pediatric Anesthesiologists. Madam is national coordinator for many courses. She is reviewer of many journals like Airways and JOACP. So it's a great opportunity for us to listen to you, ma'am. So the platform is all yours.
Thank you very much, Dr. Arora, Dr. Balde, and Dr. Bhure. And I really consider it a great honor to be invited for this meeting. I'd like to share my screen. Can you see my slides?
Yes, ma'am.
And you can hear me speak clearly?
Yes, ma'am.
Okay. Well, thank you very much, and a very good morning to all of you. We have a good number attending this meeting. And I particularly am happy that you've chosen this topic, especially since you've caught it while the iron is hot, in the sense that you did a case and you had a problem, and that is the best time to discuss these issues. So today I plan to cover my objectives over the next half hour or so, is to highlight some of the issues as to why has minimally invasive surgery gained popularity. It's not just for cosmetic reasons alone, and we'll talk about that. We will discuss what are the physiological changes due to minimal invasive surgery, especially related to raised intra-abdominal pressure. And that what will follow then is the perioperative anesthetic concerns and management. I think we need to particularly stress, just as Dr. Borde mentioned, the importance of vigilance and team communication, because outcomes depend a lot on this. We need to highlight some of the expected complications and management. And I'd like to end with a little bit about post-op pain management, because there's a lot of people think that when you have laparoscopic surgery, you don't have much pain, and that's not really true. So with these objectives in mind, I plunge ahead, and we'll talk about why minimally invasive surgery has gained popularity. As Dr. Balde mentioned, he was in a situation and it was a nightmare. And I can tell you, this is not my most popular anesthetic to provide. But yet, we've had to learn how to survive all these very adverse situations that can occur with these new procedures. So obviously, one of the most, what is very, makes a big difference in a patient's life and in turnover in a hospital is that if surgery goes well and all is well, the hospital stays much less. There's a slightly lower rate of infection. In fact, there are some studies where they have compared, say, in appendicular abscesses, whether it's been done as an open procedure or with a laparoscopic procedure, and found that in fact, the complication rate and the infection rates are much lower. One other big advantage, which we all know and we've seen when you had these large open surgeries, is that there is much less post-operative respiratory depression and supposedly pain, but we'll talk about that aspect. And the other huge advantage being that because of all these reasons, is much better post-operative recovery. And therefore, as a result, the costs are low, even though the surgery might be expensive per se, the number of days in hospital, etc., add it all up, turns out being less expensive. And of course, as we all would rather have a tiny scar or no scar over time, as opposed to a large incision. And as mentioned earlier in the introduction, I think probably the biggest advantage is for abdominal procedures, and where you can't really go in very well or see very well, even if you do open surgery, and that's in the pelvic and the neurological areas, which is why this is so popular. And another thing I'd like to highlight is that, in fact, for a surgeon, like for instance, if you have a child who has a unilateral hernia, especially sometimes in girls, they found that when they do a laparoscopic, they've been able to, in about 66 in this particular study, 66% of patients, they found that there was, in fact, on looking laparoscopic, vaginalis, and so. Sorry? I think there's somebody's. Can you please unmute yourself? So, in fact, surgeons have been able to diagnose associated either congenital or other problems because they have a laparoscopy, and they've been able to then proceed or diagnose a problem. So to move further, I mean, here obviously there's a huge advantage. For instance, this is taken post-op in a baby who's had a tracheoesophageal fistula. Normally, you would have had a fairly large incision somewhere made in the chest, and this baby just has 3 little scars. Or in this child who's had a congenital diaphragmatic hernia repair, normally you would have had a very large subcostal incision, and whereas here you can barely see anything about 3 weeks later. So huge advantage. But and I think one of the most frustrating for us as anesthesiologists is access is so difficult, because you have a tiny baby, it might be a neonate. The surgeon says, I want the baby right at the foot end, I want him at the edge, I don't want the head facing the machine, and I want to stand at the head end. So you hardly have any access to a baby. And a lot of us would want to see a little bit of skin, have a hand on the pulse, be able to see the tube, and very often you can't do that. And you have to pay particular attention to intra-abdominal pressures, because they're small children, and though their abdominal walls are compliant, they are going to be very sensitive to raised intra-abdominal pressures. And what happens very often at the initiation in small babies, especially in neonates, when you start the initial process of insufflation of gas, often you might see a vagal response and a bradycardia, which you might have to deal with. It doesn't mean you have to stop, but you're likely to have this. In the earlier days when we used to use cold gas, very often it was very difficult to maintain body temperature in these children. So we'll talk about some of the newer machines that are available that actually warm the gas, carbon dioxide. Now, you and I for open surgeries, we have certain formulas for giving fluids to children. And this is a little confusing when you're dealing with laparoscopic procedures in children. We'll talk about that. And here, you can't just sit back and play Sudoku or say, you actually have to depend almost entirely on being vigilant and communicating to the surgeon. But we're watching so many things because, as mentioned in the introduction, you can very easily have a problem. You're not sure what's the situation. All you're seeing is a desaturation. You are the one who has to make the quick decisions. So let's talk a little bit about, I think I'll have to go. Sorry. Yeah. So about the physiological implications. As I've already mentioned, this is the most important factor, the fact that you're increasing intra-abdominal pressures. And then that in babies who have a large surface area of peritoneal covering compared to body weight, there is going to be a considerable amount of carbon dioxide absorption. And probably one of the things in this laparoscopic surgery is the positioning. And patients are positioned in all the possible odd positions which you have to handle and all the implications of that, which we'll talk about. So let's talk a little bit about the respiratory. Now, we all know that with the upward movement of the diaphragm and Trendelenburg position, and even just giving anesthesia, there's going to be a reduction in the functional residual capacity. And all this ultimately contributes to alveolar collapse. And there's also decreased lung compliance because movement, up and down movement of the diaphragm is restricted. And also what happens is, therefore, the intrathoracic pressures go up and the peak pressures go up, and there's a lot of resistance to ventilation. And ultimately, what that leads to is this terrible situation of the pulse oximeter making this dreaded low-pitch sound, which we all hate. And so what is so crucial when we talk about how to minimize this is that we need to obviously limit abdominal pressures. And what are these? Well, obviously, there's going to be sometimes a reduction in venous return, and then you change the position and you have an improvement in venous return. So it's a fluctuating situation. And because of the resistance to flow and the increased systemic vascular resistance, you will also have a reduced aortic blood flow, and perfusion is compromised. And we're also talking about reduced stroke volumes. And as I mentioned earlier, arrhythmias, because you can have bradycardias, you can have various other arrhythmias which can occur because of hypercarbia, and in some situations, cardiac arrest. So not easy. You've got to really be anticipating if something is moving fast. But the good news is that these changes are temporary and they do reverse when the pneumoperitoneum is terminated. Now, we also need to know that, say you're doing a long or prolonged procedure and you put in a urinary catheter, and then you think, oh, I have not given enough fluids because the urine output is down. It's not because necessarily the child is low on volume. It's because of the effect of intra-abdominal pressure on renal blood flow and therefore renal function and therefore a reduced cardiac output. And then when you think of small babies, especially the neonates, they'll also be, because of the venous pressures going up and because of positioning, there's going to be an effect on intracranial pressures and cerebral perfusion pressures. So that is a big concern. And we need to ensure that, that they are, if there is a doubt, that you need to be alerted to it. And as I mentioned earlier, carbon dioxide gets absorbed, and therefore you will have acid-base modifications. And the important thing, as I mentioned, is that especially in neonates and infants, because of the larger surface to area of weight and peritoneal area, there is much more carbon dioxide absorption in these smaller babies than in, say, the older ones or in adults. So what is so crucial is from the time the trocar is in and the surgeon starts insufflating, you need to watch, and it's very crucial in babies and children that you do a slow and gradual insufflation. And you go very slowly, and this is about 40 times less than what you would have in an adult. So it's very significant. And as I mentioned earlier, it's important that these gases are warm, because you could suddenly blast cold air into the abdominal cavity. That has got very major implications for both temperature monitoring and also vascular issues and vagal stimulated bradycardia. And one very important aspect that surgeons need to do is that they need to remove the air in the tubing, and they need to fill the tubing with carbon dioxide, because what happens is that otherwise initially air goes in and that stays for a much longer time, and that also contributes to problems later of say stretching of the diaphragm and shoulder pain, etc. post-op. So the issue is you've got to keep an eagle eye on what is the pressure on your CO2 on your laparoscopic machine. And what is generally recommended are these values for neonates, not exceeding 8, in infants about 10 millimeters of mercury, and in older children you can go to and in adults we're talking about 20. And the thing, thoracoscopic, as well as you do not generally use one lung ventilation along with thoracoscopy, because that combination is quite deadly, as well as if there's situations like empyema. So we move on to what's different when you're assessing these children. Not really, just use your general principles, but particularly you need to know if there's a congenital heart disease. Now you'd ask, can you do laparoscopic in children with congenital heart disease? The answer is yes, but obviously if there is gas embolism, the implications are much more, and one has to be very, very careful as to how this child, this particular child and his cardiac condition is tolerating these changes. The baby has, let's say, has been a premature baby and has problems with the lungs to start with, or is an asthmatic, you have to also be concerned. And we are also talking about adequate hydration status, let's say in a child with pyloric stenosis, etc., because obviously if they're dehydrated, and to start with, they're going to be a little more sensitive to these changes. Now, earlier, I remember when we started doing laparoscopic surgery, the question was, can you do laparoscopic surgery, for instance, in a child who has a ventricular peritoneal shunt? And the answer is yes, you can. Because remember that these shunts have one-way valves, so it doesn't go the opposite way. But I think of concern is that the surgeon has to be particularly careful that the tip of the shunt isn't blocked and it doesn't get dirtied. Otherwise, it doesn't have the flow of, doesn't allow the flow of CSF in children with VP shunts. So lab investigations really depends on the complexity of the surgery. And again, pre-medication, it's entirely up to you or your individual practice or the institutional practice. So let's talk about some of the general issues that we face as anesthesiologists during minimally invasive surgery. So we have the setup here, hardly any space. I don't even see an anesthesiologist. They're kind of relegated to the nether regions as I speak. You have absolutely no contact with all this bulky equipment. And it takes a lot of time to set it up. So it's not something you can do rapidly, and that has to be taken into account. You have to know where you're going to stand. There's much more equipment, much more crowded operating room. You have difficulty in access to the patient. Sometimes it's a prolonged surgery, especially if you have newer surgeons involved. And let me tell you, I think this is the one procedure where you're really on your toes, because you're watching your monitor. Your monitor is all that's going to tell you what's happening. You're watching your airway pressures. You're watching what's happening. Is the surgeon leaning on the chest? Is he leaning? Is somebody else leaning or something else? And so you have to be really on your toes. And so crucial is that, especially if you say you have a junior anesthetist and a very senior surgeon, like you mentioned, somebody who's flown in from the US, and you say, well, can I tell him to stop? Is it okay to tell him to stop? Yes, it is, because it's so important that you have timely communication when you are in a crucial situation. And I can't stress enough about that. So your goals as an anesthetist is you need to provide appropriate conditions. You can't say, oh, I can't do this patient with the head at the other end. If the surgeon is comfortable that the procedure is going to go much faster with that because of access, then you've got to comply. So you've got to provide good relaxation. And I can't stress enough on this. There was a time when the surgeons first started doing laparoscopic surgery. They kept asking us, and then somebody would say, oh, ma'am, I'll just give some saline. How often do I have to give a relaxant? But it's so important to know that for good exposure, you have to have a well-relaxed anterior abdominal wall. So there's plenty of space for the surgeon to operate. He doesn't want to have squeezed anterior abdominal wall. So it's so important that you have as good relaxation as possible and provide adequate pain relief. You have to be very quick in understanding what's happening to the various systems and how do you modify or rectify that. For instance, you're constantly wondering, what is this insufflation pressure? What is the effect it's having on this patient's ventilation? How do I maintain the optimum saturation? Just turning off all the anesthetic agents is not enough. Do I have to increase the tidal volume? Or do I have to reduce it? But I need to give at least some inspiratory pressure with the least amount of inspiratory pressure. Now carbon dioxide is going up. So what is acceptable for this child? What is acceptable hypercarbia? And you have to see what's the effect this is happening on the venous return, etc., as I mentioned earlier. So you have to be vigilant throughout. And with the longer complex procedures, you might have to consider putting in more invasive monitoring like arterial lines, etc. If, for instance, if you're doing a thoracoscopy and the surgeon says, I want one lung blocked, you have to know how to do a bronchoscopy and position a blocker, etc. And you need to know how to communicate with the surgeon to when do I convert this to an open procedure. That is your decision. So induction, well, it's really up to you, inhalational or IV. But one real important thing is we don't really realize when you're mask ventilating a baby how much air goes into the stomach. And so it's very crucial that you decompress the stomach, you keep an orogastric tube in before you hand over to the surgeon and before he puts in the trocar. Then the next question is IV lines. Now, you are not going to have any access to this child. So if you think it's going to be a problem, put in an extra line, preferably in the upper limb. Now, the next big question is, do I intubate with a cuffed or an uncuffed tube? Now, if you have a simple procedure with like a pyloric stenosis, maybe I would not have a cuff tube, but generally I found it's been a nightmare. If you have a tiny baby in the head down position and you almost cannot ventilate because almost all the air goes out through the leak. So it's worth putting in a safe uncuffed tube, a cuff tube, but I would really like to emphasize that you have to be monitoring intra-cuff pressures and keeping them low. Because if you have a situation of low blood pressure and high cuff pressures, this child is likely to have problems of tracheal stenosis later on. There are studies in children where for short procedures, they have put in the third generation supraglottic airway devices, where they've shown that the ventilatory patterns have not altered too much, whether you put a cuff tube or an uncuff or a supraglottic airway device. But generally, this is not too popular, and probably the safest thing is to put in an endotracheal tube. Now, how do you maintain anesthesia? It's about the same. The only thing is there is this concern. I think a lot of us have stopped using nitrous oxide anyway. So you use it for induction and then you turn it off for maintenance. Now, the important thing is you can combine regional blocks, for instance, but you have to ensure, for instance, if you're giving a caudal block, that you're giving the level high enough for where the upper incision is. And what is very crucial and what they found is most important is local infiltration within the dose required for that child per body weight, and that the surgeon actually goes right up to the peritoneum, instills there, and then all the layers of the anterior abdominal port, wall where the port sites are. There are some studies where, at least one particular study where they've spoken about that where the surgeon is actually dissecting, that they, through one of the ports, instill a little bit of local anesthetic. That actually is a little questionable because you don't know if it's staying there, is it dripping off and going somewhere else? Will that be absorbed and then add to toxicity? So not really clear about how useful this is. You would usually combine this with narcotics and paracetamol. And I can't stress enough that you do need good muscle relaxation. And your ventilatory patterns, you've got to keep adjusting, as I said. Initially, you might want to use volume controlled, and you find that it may not be suitable, then you can go to pressure controlled, and you keep having to adjust your tidal volume and respiratory rate with one aim, and that is to maintain normocarbia. Let's talk a little bit about positioning, because this is the nightmare. You have Trendelenburg, you have reverse Trendelenburg, all these, the people who are most affected are the little ones. And then you can have lithotomy, and that can cause problems on the nerves and stretching. So you have to be really careful how the babies are positioned. Very often the arm needs to be tucked in on the side of the surgeon. How you do that again is is the arm supinated, pronated? Is there going to be nerve injury? You've got to be very meticulous about cushioning these pressure points, arm, wrist, hand, because you don't want a hand drop or a wrist drop. And you, for instance, if the arm is stretched above the shoulder, you need to make sure that there's no traction, because again, you can have consequences to that. And firm strapping of the patient, because obviously once you change the position to either Trendelenburg or reverse Trendelenburg, the baby can move. So you need to strap them, really strap them so that there's no movement beyond that. And you also need to pay great attention to your ventilator tubing, your IV lines, your endotracheal tube, because you are not going to have to tell the surgeon midway, oh, you know what, I forgot to strap this. So you need to be 100% sure you're happy with that. And I would really say you need to be vigilant. You need to be the bad person there, because you need to watch anybody in the operating team leaning on your little baby and causing even more problems. And that can very easily happen. So, just to give you an example, like in one particular center, they do inguinal hernias with the child's head away from the anesthesia machine. And here you can see that the anesthetist is really relegated. He's not anywhere near. He's standing away. He's looking at the monitor, and he has no access to the patient. So monitoring is standard, but as I say, if you have more complex procedures, thoracoscopies, you might have to, or very long procedures, you might consider invasive monitoring. And one of the newer monitoring devices are the near infrared spectroscopic monitoring in neonates, because it's a trend monitor and it evaluates the balance between tissue oxidation and consumption. And so it's very crucial that you maintain that, especially in the very small babies. Temperature control, I've already spoken about, but what newer laparoscopic machines definitely warm the carbon dioxide gas, and that makes a huge difference. But you do have to ensure that you use other techniques as well. Now, a little bit about fluid maintenance. As I say, you might follow your regular 4 ml per kg or whatever, but what's important to remember is that with laparoscopic surgery, you have less of fluid shifts into the third space. There's less evaporative loss. So you might go a little low on fluids. You don't need to give too much. And we actually had one child where they were doing a renal procedure and we were giving, it was new at that time. We were giving a significant amount of fluid and the child was lying lateral for a long time and post-operatively developed pulmonary edema and because we had given too much fluid. So you need to be careful about optimizing the preload and not giving too much. A little bit about complications. Varies actually now the complication rates in good centers are at 1%, where you're starting off, it goes a bit higher. And they're all related to what we've spoken to already. And most of the problems are related to respiratory or cardiovascular, also gas embolism, especially in neonates who have a transitional circulation. And I think what's particularly important is that they might have a patent umbilical vein or a ductus venosus. And in fact, they talk about how when you're doing the periumbilical trocar, the surgeons need to be particularly careful about that. They might actually have to ligate the umbilical vein before proceeding to the trocar. And then you have vascular injuries. I remember we did have one in a slightly older child, and that was, we couldn't actually save that child because it was right deep down. And solid organ injury, all of these are things that happen, especially with slightly junior people who are on the learning curve. And what you'll realize is that most pediatric surgeons don't do anything blind. They make a nick into the peritoneum, then they put in the first trocar, and all other trocars are put in under vision. But these can occur and you need to look out. So let's talk about oxygenation and ventilatory problems. Well, because of all these changes in position, the endotracheal tube can migrate. It can migrate out, it can migrate in, and you need to be aware especially if it's gone down one lung. Pneumothorax, pneumomediastinum, I think that's probably what occurred in your patient, Dr. Barde, where the pneumomediastinum might have been significant when they were resecting the stomach, and it actually tracks all the way up and then through the neck. And sometimes you can't even, if you have early pneumomediastinum, it may not even show up on an X-ray. Problems related to excess intra-abdominal pressure, patient positioning, as I mentioned. Bronchospasm, again, this might happen, say, if your tube has migrated down, and atelectasis, aspiration, again, because of positioning, or if you have an uncuffed tube, and all the problems related to a falling cardiac output. So how do you deal with this? Well, first you have to rule out bronchial intubation, or so for that, or bronchospasm. So you increase your FiO2, like was mentioned. You need to optimize PEEP. And then if it does not resolve, you need to ask the surgeon, reduce the pneumoperitoneum and convert to open surgery. What about CO2 absorption and hypercarbia? What do you do? Well, as I mentioned earlier, you need to first play around with the minute ventilation, go up on your tidal volume, you go up on your respiratory rate, and the whole idea is that you do this to try and maintain normocarbia, and if it's not possible, Now, I'd just like to mention here that for those of us who used HMEs, that's the heat and moisture gadgets for neonates, that can also contribute to dead space and can contribute to hypercarbia. So you have to be a little cautious about that. If you find that nothing works, sometimes removing the HME can help. So sometimes, as mentioned earlier, you may have to require ventilation post-operatively, especially if there's excessive carbon dioxide, and it takes some time to remove it. You can't expect it to, but I can't stress enough that you need to convert to open surgery if the EtCO2 remains excessively high. What about vascular injury? Not too common, but it does require surgical repair. And usually it occurs during that initial entry. The majority of complications, vascular complications, have occurred with the initial entry or the placement of trocars. And you need to suspect it if they're unexplained hypotension, or if they're seeing a visible bleed. But very often you may not see a bleed because the pooling of the blood is very often away from the surgical site. So it's up to you really. You need to say, hey, I'm not happy. This pressure's gone suddenly low, and you need to suspect that. And you need to inform the surgeon, because then a decision has to be made to open up. What about venous gas embolism? So again, this is usually subclinical, but you need to suspect it if there's unexplained hypotension, there's hypoxia, or if there's a sudden drop in your EtCO2, because there's no forward flow from the pulmonary veins into the heart. And so what do? You immediately deflate the abdomen. You can give fluid boluses, and then you have to make your decision as to what to do next. You might have to give vasopressors as well. I'm going to talk now a little bit about the procedures that are done, and different centers have them in different places. So this is for the commonest inguinal hernia repair, commonest surgery that's being done in children. Here, fortunately, the position is supine, but some surgeons actually want the head end at the opposite side of the anesthesia machine. So you're going to be standing there, and you have no access to the head. So you find that the tubings will run along the side of the child, well protected, and you are actually in least control. But the good news is that this is a short procedure. Now, the question was asked to me some time ago, is that why, a hernia ought to be in a baby, such a simple procedure to do. Why do they want to do it laparoscopically? And that's one of the reasons why surgeons prefer to do that. I've mentioned in one of my earlier slides, is that they have actually found that they've diagnosed bilateral hernias only after going in with the laparoscope, and also associated problems with the sexual organs, especially in female children who have hernias. So here you see that the IV has got extensions, and this arm is nice. All the tubing is wrapped up nicely, so that even if somebody leans on it, it's not going to cause. So there's a lot of, what about diaphragmatic hernia repair? Here again, the surgeon would like to have the child more on one side so that he can stand near the patient. You have the arms stretched, you need to make sure they're well taped, etc., that your tubing is well taped. And here the surgeon is going to be standing at the head end. So you don't have to give one lung ventilation, but you have to watch them very carefully, and you have to, again, decide if it's causing too much problem, they might have to proceed with the open. And so this is a diagrammatic representation of that, where again, you can see you're having everything extended, and you're all standing here, and these guys are all here. Now, when they do tracheoesophageal repairs, sometimes they put the baby transversely across. Again, you're sitting here, so you have, this is the side access you might have to the child, with the surgeon occupying this area. You have to plan what you're going to do. You need to have your IVs where you can watch, and your anesthetic machine in a location where you can see. Now, a little bit about esophageal atresia. Again, here's semi-prone with the right side elevated. You might have to put an endobronchial tube or an endotracheal tube. And what's here, your role is going to be that when the surgeon wants it, he will ask you to pass this trans-anastomotic tube. So you need to have it readily in position, and that he can then pass it in from the esophageal pouch. About pyloric stenosis, again, the important thing here is that they'll ask you, initially you've got to empty the stomach because there's a lot of stuff there and you don't want the child to aspirate. But then once the surgeon has performed release the muscle, he'll ask you to actually inflate air into the stomach, so that he wants to make sure that there is no tear in the mucosa. And interestingly enough, when you look at studies in babies who've had laparoscopic surgery for pyloric stenosis, the incidence of injury to the mucosa is higher with laparoscopic procedures as compared to open. Here again, you're talking about positioning. You have hardly any space. You're also worried about pressure, the stretching of this arm. And you have to make sure that it's not stretched too much because the surgeon doesn't want the scapula in the way. Again, lobectomies, they're here. This is again quite difficult. You usually have to have additional lines and arterial lines, very close monitoring. And the problem here is that you can have little blood entering the tube and you can block the airway and you need to suction. And so you need to have that available and access to the tube for that. Now, a little bit about post-laparoscopic pain. Now, it's well known that the pain following abdominal laparoscopy is less than open. But the point is, do small wounds pain less? Does that mean you don't bother about post-op pain? And the answer is no, because there's substantial evidence that post-operative pain is common after, say, a lap appendectomy, and 1 in 3 children experience significant pain on the day of surgery, and 1 in 5 even on day 2. So the point is, and also, if you have remainder of air or gas in the abdomen, children, there is this problem of shoulder pain, which can be incidence can be as high as 35% after, say, appendectomy. So why is laparoscopic surgery painful? There are only tiny incisions, but there are several factors involved here. You're going to get pain from the trocar site. Has anybody had laparoscopy among the audience? I have. And I can say, my surgeon said, oh, you can play golf a week after. And I couldn't. I said the only resemblance of me and golf was I looked like a golf stick club, in the sense that I had pain in my abdomen, because you feel the visceral pain. And there's visible manipulation and traction, which lasts for some time. The CO2 insufflation actually distends the peritoneum, and it stretches the diaphragm and it irritates the diaphragm, and that has long-term pain. The phrenic nerve is also stretched, so you can get neuropraxia, and actually the gas irritates the nerve itself. You have release of inflammatory mediators and the irritation of the blood vessels. And as I very importantly said, if there's a little bit of remaining gas, you're going to have the likelihood of shoulder pain occurring. So it's so important that the surgeon ensures that as much of the gas insufflated is removed. So what would be the analgesic regime? You give enough pain relief for the first 24 hours, use multimodal strategies. As I mentioned, nerve blocks, the studies which have shown rectus sheath block, tap block, quadriceps block, all of them have to be combined with the local infiltration and acetaminophen. And if you're giving caudal, as I said, you have to make sure that you have an adequate level so that it includes the highest incision. And there is no optimum analgesic regime. You've got to play it by ear. So in summary, I can't stress enough that the pre-op team discussion to plan, especially if there's the procedure is not being performed very often, is so crucial. You need to know what does the surgeon want, and you need to monitor so closely. You have to have a good understanding of what are the potential complications, and you need to communicate to the surgeon if there are concerns, and you tell him to convert to open if you think this situation calls for it. Thank you very much.
Thank you, ma'am, for your brilliant, elaborate talk. I think most of the questions regarding anesthesia for laparoscopic surgery in pediatric patients have already been answered. But if anybody is having any question, can put it in the chat box, and we'll take up the questions later on after the session is over. And I will request all the attending delegates to please keep their microphone on mute mode. Otherwise, it is causing a lot of disturbances. Now we will move on to the next topic, that is anesthesia for laparoscopic surgery in patients with complicated comorbidities. And to speak on this subject, we have our eminent faculty, Dr. H.M. Krishna sir. Let me introduce him. He is a professor and head of the department at Kasturba Medical College, Nagpur. And his area of interest is pediatric anesthesia and simulation in anesthesia. And he has more than 40 publications to his credit. Sir, the platform is all yours. Saurabh, can we have the presentation from him?
Yes. This is a video presentation. This is being
It's a recorded
shared by Janika people.
Okay. Can we have the presentation, please?
City branch.
Okay, I think he is trying to play. Let me see.
Yes.
If that is not possible,
In conducting this.
Has he logged in?
Oh, sorry. Yes, sir.
Deepak, you share it.
yes, I can try. I'm trying from my side. Okay, is it visible?
Yes.
Yes.
Okay, I'm playing now.
I would like to thank the ISC Nagpur City branch for inviting me for this webinar. I congratulate all the office bearers in conducting this webinar, which I'm sure will be very useful to the daily. As I start sharing my screen,
There's some problem with the sound.
laparoscopic surgery in patients with complicated comorbidity. Over the next 20 minutes or so, I'll try to keep the things as simple as possible. Now, the topic says that complex comorbidities, but unless we simplify the things and make things as simple as possible, we fail to understand the complexities behind it. So let's simplify things so that we understand them better, and then we are capable of doing even the complicated things. Let's understand the systemic changes that happen during the laparoscopic surgery. Though this might seem to be a repetition over and over, unless we understand these systemic changes which happen during the laparoscopic surgeries, we cannot clearly define our goals when we are conducting anesthesia on patients with complex comorbidity. We need to understand what implications, what impact those systemic changes have on the comorbidities that the patient is having. And then we'll go through a couple of case scenarios so that we can have a real feel of how we manage these patients. The advantages of laparoscopic surgeries are very well advertised. The surgeon is convinced about that, and the surgeon advertises that. The patients want to get operated by the laparoscopic surgery because they have heard, seen in the media the various advantages that are given. Everybody acknowledges that it's a new thing in and it's modern and there are several benefits. But it's only the anesthetist, it seems, who has some reservations still about the laparoscopic surgery because we go by the facts. We are not bothered about the advertisements behind the laparoscopic surgery, but we are really interested to know whether it is beneficial indeed to the patient, whether the patient is going to be better with a laparoscopic surgery or an open procedure. So it's not that the anesthetists are cynical to adapt something which is new, to get modernized, but we are behind the facts and we go by the facts. And that's the reason why we always think twice before choosing whether it has to be a laparoscopic surgery or an open procedure for the patient. When a patient has a comorbidity, be it diabetes mellitus, hypertension, ischemic heart disease, or it could be the hyper responsive disorders of the airway, could be like the asthma, the emphysema, or it could be endocrinological disease. There's a whole array of comorbidities that a human being can have. What is concerned to us as anesthesiologists is physiologic reserve in the patient. As the intensity of the comorbidity increases, the physiologic reserve of the patient progressively decreases, and this is a matter of concern to us as anesthesiologists. Because if the physiologic reserve is good, there's a lot to play around. The patient would tolerate a heart rate right from 50 beats per minute, even up to 180 beats per minute without any problem. But when the physiologic reserve of the cardiovascular system is diminished, the range in which we can work would probably be something like between 80 beats per minute to 110 beats per minute. Anything more than 110 beats per minute, we are going to see the harmful effects. Anything less than 80 beats per minute, so the amount of errors that we can make with the physiologic reserve is diminished. We cannot make mistakes, errors in these patients. The safety of anesthesia also progressively decreases as physiological reserve of the patient decreases. So these are the two things. We cannot make errors, and the safety of anesthesia decreases when the physiologic reserve of the patient. There are a lot of physiological changes that happen during laparoscopic surgery. We call it physiologic because they will happen when laparoscopic is initiated. They cannot get away without that. It comes along with laparoscopic surgery. There are two main reasons behind that. One is the position of the patient. Patients are positioned to facilitate the surgery. There are various different types of positions that occur that are maintained for the surgery. So those positions will bring about some changes. And the second one is that we are creating a pneumoperitoneum. The pneumoperitoneum itself will cause the physiological. The commonest positions which are adopted for laparoscopic surgery are one is the Trendelenburg position, which is by definition about 15 to 20 degrees head down. So we see all sorts of head down positions and extremes, almost the Shirshasana, patient falling off the table, ready to fall off the table. The surgeon wants that for better surgical approach to the patient, but then the consequences and the side effects are borne by the patient and managed by us. So when a patient is in Trendelenburg position, head down, obviously common sense, the abdominal contents are pushed up, the diaphragm is pushed up, so the functional residual capacity decreases because the basal area of the lungs are compressed by the diaphragm. And because things are migrating upwards, what happens is the tube tends to move in, and we could have a problem with the endobronchial infection. Now, because the patient is head down, all the blood that would have been moved in the peripheries, like the legs and the hands, they tend to come in towards the heart, which increases the preload due to an increase in venous return. It's not just the cardiorespiratory changes that we are concerned with. It's not just that that's happening, but we are not careful enough. There could be a whole lot of pressure effects like the nerves, common peroneal nerves, the dichotomy position, the brachial plexus, all these could get injured and affected if we are not careful. The reverse Trendelenburg position, as we see commonly with the seems to be, the tidal volume seems to be improving. There's better space for the lungs to move. But what happens with the cardiovascular system is that all the blood starts pooling in the extremities, and hence there's a decreased venous return to the heart. There's a reduction in the preload, and this could result in hypotension. And pooling of the blood could also predispose the patient if the thrombosis. Normally, there's not any pressure in the intra-abdominal space. It's almost 0 to 5 millimeters of mercury. When gas is insufflated into the peritoneal cavity, we create a pneumoperitoneum and the intra-abdominal pressure increases. We have the monitor on the laparoscopic equipment which monitors this intra-abdominal pressure, and our vision should always be on that numbers because it's important to monitor the intra-abdominal pressure. We have all been taught that an intra-abdominal pressure of 8 to 12 millimeters of mercury is ideal, appropriate. Once again, we need to monitor because this can be superseded and can be increased by the technician or the surgeon. The initial rate of gas flow is quite high, 4 to 6 liters per minute. That's only because we are all in the constraints of time. We want things to move fast, so we just rush in the air there to create the pneumoperitoneum fast, which might not be advisable in many conditions. So it's not that it's default for all cases to have a gas insufflation rate of 4 to 6 liters per minute. There are situations where you will have to readjust it, bring this down. Subsequently, the maintenance flow rates would be around 200 to 400 ml per minute. So once pneumoperitoneum is created, why the physiological changes with respect to cardiovascular system, respiratory system happen is because the mechanical effects of the gas that we have put in the peritoneum cavity. There's a pressure created in the intra-abdominal compartment. That pressure will cause its effect. The duration for which we maintain the pneumoperitoneum is important. How much of volume is going in and is getting absorbed into circulation is important. What gas we use, commonly I don't think any other gas, it's universally almost carbon dioxide now. So that matters, and in what form, physical form the gas is, how dry it is, the temperature of the gas, these things do matter. There are three mechanisms by which the pneumoperitoneum is going to affect. One is by the mechanical effect, stretching, like pressure and compression, because we have put the gas. The chemical effect of carbon dioxide. Carbon dioxide gets progressively absorbed into the systemic circulation, and it causes respiratory acidosis. So thereby it gives us the chemical effect. And third one is because of the physical property of the gas. Gases are all cool and dry, and because of that, we have the desiccation effects. In general, the mechanical effects are as the intra-abdominal pressure increases, the heart rate increases, the arterial increases, the systemic and pulmonary vascular resistance increases, and always these changes happen. Initially when gas is going into the intraperitoneal compartment, the stimulation of the stretch receptors there could trigger severe bradycardia, which can even progress always. Not be under the always tachycardia, always hypertension. It depends on several other patient factors also. And this is where the influence of the comorbidities come. How good is the autonomic nervous system compensate for these physiology? Good, or there is no compensation. So because of these pressure effects, the tissue perfusion of the abdominal contents in general is reduced, and that affects the tissue oxygenation to various extents. So, from what is recommended, 10 to 15 millimeters of mercury of intra-abdominal pressure, increase even by a little of 5 millimeters of mercury. We see that there is a significant reduction in the blood flow, stomach, the jejunum, the colon, the abdominal viscera. So that's the importance of maintaining the abdominal pressure. Progressively, carbon dioxide gets absorbed into the circulation, hypercapnia and respiratory acidosis. How much of it gets absorbed depends again on the amount of intra-abdominal pressure, position of the patient, and duration of the cardiovascular effects that we see in the laparoscopic surgery are mainly because of acidosis induced by the carbon dioxide absorption. Carbon dioxide sympathetic nervous system causing a release of catecholamines from the adrenal medulla. No wonder we are seeing hypertension, tachycardia. They are all manifestations of sympathetic. So the duration and level of intra-abdominal pressure are important here. It's not just the cardiovascular and the respiratory changes. Remember, after about 15 minutes of carbon dioxide consumption, we start seeing an increase in the intracranial pressure also. Why? Because the effects of carbon dioxide on cerebral circulation causes cerebral vasodilation and increase in intracranial. That's why there is a comorbidity related to the CMS. It's an intracranial pathology. There are features of increased intracranial pressure. We need to pay a lot of attention to this acidosis that is resulting because of carbon dioxide absorption. Usually, this is very simple to manage. We just have to increase the minute ventilation by 10 to 25%. There's not much scope of increase in the tidal volume because the abdominal contents are already put up. If you try to increase the tidal volume, it just goes up. So what suits better is to increase the respiratory rate to increase the minute volume. So the side effects of the carbon dioxide can actually be mitigated very easily by increasing the alveolar ventilation. So under general anesthesia, this increase in the carbon dioxide tension, it happens progressively during the initial few minutes of hemoperiton, and it reaches subsequently a plateau after about 30 minutes. Because the gases that we are insufflating into the abdomen are cold and dry, there's a problem of hypothermia and interference with the breathing. So let's move on to some case scenario and see how things would be different with respect to the laparoscopic surgery. The 65-year-old man, a known case of chronic obstructive pulmonary disease, has come for a surgery. He has bilateral scattered bronchi despite optimization of bronchodilator therapy. He's receiving all the nebulizations, beta-reduced inhalers. Chest infection has been ruled out and is optimized with respect to infection, possible infection that would have been here. His FEV1 by FVC ratio is 40%. And since pulmonary function tests were done, There's no reversible obstructive component. Most often, these are the two important messages, information that we get from pulmonary function test. What's the severity of the obstruction and how much is the reversible component in that obstruction? Now, if he's posted for laparoscopic cholecystectomy, would we like to take up or would we want to go for an open surgery or would we want more optimization? What if it were to be a laparoscopic inguinal hernia repair? Would we choose the open procedure or would we go for a laparoscopic hernia repair? So what's of concern to us mainly in this patient is the respiratory system. Pneumoperitoneum increases intra-abdominal pressure, elevates the diaphragm, causes the collapse of the basal lung tissue, reduces the functional residual capacity. There's a mismatch between the ventilation and the lung perfusion that is happening, which causes an increase in the intrapulmonary shunting of the blood. So all in all, this predisposes the patient to hypoxia. And if the patient has already a compromised respiratory function, this hypoxia will be aggravated worsen. So would the patient tolerate this hypoxia or not is the question that we have asked for ourselves. CO2 absorption results in hypercapnia acidosis, and we already know that the gas exchange is there in the their basal carbon dioxide levels itself would be elevated. On top of this, we are adding more carbon dioxide to the plant. Would that be tolerated or not? Another thing. Ask for ourselves. The functional residual capacity decreases by 20 to 25%. So whatever pulmonary reserve is there, that is taken off from them. The compliance decreases. The airway resistance increases. They are already having hyperreactive airways. On top of that, the airway resistance. But what's good is, once the procedure is over, the surgery is over, immediately, within about 15 minutes of abdominal dilation, all these parameters, compliance and the resistance, they return back to the pre-insufficient level. So what's the solution? Should we postpone the surgery, hoping that we can optimize the patient further? Should we decide for an open procedure or should we go ahead with the surgery? There are very simple solutions. As I said, the gist lies in simplifying things and not complicating. What did we say? There's a basal collapse of the lung, there's a reduction in the FRC, the diaphragm is pushing up. Why not counter that? We can give a peak, something starting with 5 millimeters of mercury and then titrate it as required, which will counter all the effects of reduced FRC, basal atelectasis, hypoxemia, worsening ventilation perfusion mismatch. All these can be countered with just your ventilatory adjustment of the peak of around 5 to 10 millimeters of mercury. There's an increased intrapulmonary shunting, so let's adjust for that and if required, increase the FIU. Normally we use about 50% of FIU. We could increase it to about say 40-45% during the laparoscopic procedure. We couldn't do much harm for the duration of surgery. We don't want the effects of carbon dioxide, so let's wash away the carbon dioxide, increase the alveolar ventilation, increase the minute ventilation, adjust your ventilatory settings, increase the respiratory rate by about 10%. So the solution seems to be very simple to the physiologic problems imposed by the laparoscopic surgery. When we are dealing with any patient with respiratory comorbidity, the key elements in making the decision are the surgical expertise and the duration of surgery. Then there are complicated, complex comorbidities. These are not the patients for the surgeon to improve this learning curve to learn from these patients. There is no potential to make the problems and complications of these patients. So the surgeon is good, the surgery is good, our patients will be. If he isn't experienced, if he is not good at that, we are going to have a lot of problems. Shorter the surgery, better the outcome. The perioperative management of the pulmonary disease per se in laparoscopic surgery is not. Your choice of patients, your preoperative evaluation, optimization of the patient, bronchodilator therapy, they all remain the same as for any other surgery, any other operator. So make sure the bronchodilator therapy is optimized and it is continued perioperative. The key element is the depth of anesthesia in pulmonary. Do not handle, do not instrument, whether it is AV instrumentation or surgical instrumentation, in lighter plane. Always err on deeper planes of anesthesia. Nothing is going to happen in deeper plane of anesthesia. All problems can be attributed lighter plane. So if you see the course of anesthesia, the only time when the patient needs to be light is when the patient is waking up from anesthesia. That's when he has to lighten up, wake up, and then wake up. But all other times of anesthesia surgery, there's no reason why the patient should lighten up or be in lighter state. So actually the choice of anesthetics wouldn't matter much. Hydrocodone, propofol, ketamine, all would do the same as long as the attention maintained at that purpose. Similarly, for maintenance of anesthesia, whether it is isoflurane, sevoflurane, halodine, it will not matter because you are not inducing anesthesia with these agents. You are maintaining the depth of anesthesia with these agents. It doesn't matter. They are all theoretical, saying that one agent has more bronchodilator effect than another, one is better than another, less irritating. No. As long as you ensure that you are giving things in the right dose and maintaining the depth of anesthesia, they are equally good. Yes, theoretically, academically, we could say that ketamine is a better agent. It has better bronchodilator effect. Propofol is probably better than iodine. Isoflurane has some irritant effects, so probably might not be good in the lighter plane. Yeah, so those are all theoretical, but if you pay attention to maintaining the depth of anesthesia, most of the problems in pulmonary are solved. We know problems could happen. We know the list of problems that could happen. We know how to manage bronchospasm. So let's keep prepared. Keep the drugs ready, keep the things ready, have the protocols ready, algorithms. You have had made some simulations, mock drills in the past so that when you just have stepwise one, then it's as simple as that. Pay attention to the post-operative care. Make sure that the pain is taken care of. Make sure that the patient goes through the respiratory exercises in the post-operative care. Make sure that he doesn't go into pulmonary attack cases and post-operative pulmonary complications. So pay attention to the post-operative respiratory rehabilitation. This is as good as for any non-laparoscopic surgery. Let's move on to another case scenario. A 55-year-old woman, known case of diabetes mellitus on insulin therapy and ischemic heart disease. She has had a stent to her coronaries 2 years back, and she's on aspirin therapy. When we elicited the history, we found that she has a moderate effort tolerance. Her echocardiography showed that she has an ejection fraction of 40%, diastolic dysfunction. The gynecologist is keen to a laparoscopic assisted vagina hysterectomy. So what should we say? No to an open procedure and just give a spinal and let's get away? Or should we say, go ahead with laparoscopic assisted vagina hysterectomy? Because you have said that there are so many advantages benefits. You are also convinced to some extent. The patient wants the laparoscopy. Let's do it. So how do we make the decision? How do we go about it? So if we review the effects of laparoscopy on the cardiovascular system, both because of the mechanical and chemical effects. The mechanical effects compress the inferior vena cava, reduction in the venous return, which decreases cardiac output, which means patient can have severe hypotension in the initial period, which might not be tolerated well in patients with heart. And the effects of carbon dioxide is actually the balance between the stimulatory effect of carbon dioxide on the sympathetic nervous system and the direct depressant effect of the carbon dioxide on the cardiovascular system. Usually, the stimulatory effect predominates over the depressant effect, but you never know. It depends on the patient and the patient's nervous system. Hence, these patients could have tachycardia secondary to acidosis and sympathetic stimulation, or because of the direct cardiac depressant action and the stimulation of the stretch receptors, they could have tachycardia. So you never know. This patient can have tachycardia or bradycardia. Because of the irritability of the myocardium, it could have an array of the arrhythmias happening. Then we need to be prepared. So what's the solution? Again, the solutions are quite simple. Keep the intra-abdominal pressure lower. Make sure that the patient is not hypovolemic. The hypovolemic patient would more likely go into an asystole as soon as chemotherapy. That the preoperative titration. You don't want excessive carbon dioxide buildup in the blood. The best way to do that is continuously monitor the entitled carbon dioxide and adjust your ventilation technique as per that. From the perspective of diabetes mellitus, probably, or that's what it is claimed, that there is less surgical response, stress response due to laparoscopy. And this could result in better preoperative glycemic control. This is debatable because there also is an argument that the visceral injury from laparoscopy is in fact more than an open surgery. And this benefit may not be there if that is so. Anyway, there is a claim that there is a less surgical stress response which could lead in better glycemic control. Remember, chronic diabetes is associated with autonomic neuropathy. So if there is an autonomic neuropathy, the compensatory response in the patient to hypotension and position changes that are done during laparoscopic surgeries are lost. So there could be severe bradycardia, exaggerated tachycardias, hypotension, whatever hemodynamic changes we just described can all be very severe. From the perspective of ischemic heart disease, hypotension can be there, hypertension can be there, brady can be there, tachy can be there, and all these are unwanted in ischemic heart disease. So how do we go about this? Is there any way of preventing this, managing this, treating this? Before we go on, we also need to be aware that in all these patients, it's not just the heart and the lungs that are getting involved. The renal system is also involved. There is reduced renal perfusion, which cause oliguria. The key element to prevent the renal harmful effects is to maintain normal volume. And with respect to gastrointestinal system, there could be regurgitation of gastric contents, and that brings about a whole debate of using the supraglottic devices for laparoscopic procedures. Hence, we always make sure that the gastric decompression is done in laparoscopy. So for any laparoscopic surgery in patient with we need to be attended. Which anesthesia would be better? Is it general anesthesia or which? So suppose it's a severe pulmonary disease and the patient has spinal hernia, which can be got away with a regional anesthesia without instrumentation of the airway. Would I choose a laparoscopic hernia repair or would I go for an open procedure? Probably, evidently, obviously, a regional anesthetic procedure in this patient is beneficial. So when we are making decisions, the points that we think about is whether it is general anesthesia, which is good for the patient, or whether it is regional anesthesia, which give added benefits over general anesthesia. What's the skill, expertise, experience, and the speed of the surgeon? It does matter very much when we are making decisions. When we are positioning the patient, go slow, go slow. The physiologic reserve in the patients with comorbidities is less. So they do not have the ability to accommodate, compensate for these changes. So when you are putting the patient to say Trendelenburg position, go 5 degrees every time, wait for 2 minutes, see the hemodynamic changes, what happens to the heart rate, what happens to the blood pressure. When it is nothing much, then go further down and stick to those values. When we say 10 to 15 degrees, it is 10 to 15 degrees. Not go. Be very friendly in terms of accommodating the request of the surgeon in these patients. Keep a continuous watch on the intra-abdominal pressure and gas flow. The pressures are 10 to 12 millimeters of mercury. Most of the harmful effects are mitigated, avoided. So there are a lot of preventive elements in the management when we are doing a laparoscopic surgery. Don't initiate pneumoperitoneum laparoscopic surgery in a dehydrated hypovolemic patient. Ensure that we are normovolemic so that the hemodynamic responses are not stagnated in these patients. The choice of drugs are actually similar to that in non-laparoscopic surgery. What matters is how you use these drugs and what drugs you use. The choice of monitoring, again, in laparoscopic surgery, there is no special monitor for laparoscopic surgery other than the intra-abdominal pressure and the gas flow. How invasive urine monitoring depends on the severity and the extent of the severity of the comorbidities. You anticipate the problems, complications, whether it is hemodynamic disturbances, bronchospasm, increased intracranial pressure, oliguria that could happen, and be prepared to manage them. If we fine-tune our ventilatory management strategy in terms of innate ventilation, allowing the peak airway pressures to be within the prescribed limits, judicious use of PEEP, then most of the complications or problems related to pulmonary system could be avoided or managed. A good communication, discussion with surgeon needs to be told again and again. Little things matter a lot. Just because we are doing a respiratory case, it doesn't mean that our focus is always on the respiratory system. Attention, positioning of the patient, protection of the eyes. We don't want the laparoscopic instruments coming and poking the eyes. Little things matter. Conclude. The clear anesthetic goals with respect to the comorbid condition must be clear in our minds. But a good practice to jot them down so that we know what is the problem. You should have a clear, in-depth understanding, though there could be a lot of repetitions in the lectures of the physiologic changes happening in laparoscopic. We need to nail down in that stage because when we know what is happening during the laparoscopic, and when we have clear defined goals with respect to comorbidity, we can match these either test. Thank you very much once again, and thank you.
Thank you, H.M. Krishna, sir. Sir, are you there? Have you logged in?
Yes, he is there.
Yes, I have logged in.
I thank both our esteemed speakers. Now, can we have the question answers? Varghese ma'am? Varghese ma'am is also there?
Yes, I'm here. Yeah. I don't see any questions on the chat, so I wasn't.
Actually, I had asked for questions from our members, and personal WhatsApp. So they have few questions which we would like to have the answer from you.
Sure, if I can.
Ma'am, what is the most common problem that is encountered in pediatric laparoscopic surgery? The commonest problem that we face in pediatric laparoscopy.
The commonest, I mean, it's this, I feel the biggest problem is having, especially if you have an uncuffed tube, your hand, and you're trying to make sure that you're keeping up adequate tidal volumes. And it depends on your setup. That's why I feel when those setups that start laparoscopic surgery without the proper anesthesia machines and anesthesia equipment, it really becomes very, very difficult. And so when people are, institution is willing to spend a lot of money on laparoscopic equipment, I think the anesthesiologist should also ensure that they have the modern anesthesia machines, etc. Because that's when, how do you ensure, like Dr. Krishna said, adequate tidal volumes, maintaining saturations. You can't do this with holding a bag and mechanically ventilating. You need these specialized ventilators, so you can play around with PEEP, you can play around with peak inspiratory pressures, and that's how you can overcome that. So that has been the biggest nightmare in my experience of keeping up saturations. I've had situations where the tube has gone down one lung and you can't access. So I usually stick a little stethoscope. I've always have a stethoscope stuck on the chest so that I can pick up the sound early without having to put my hand there and disturb the surgeon. And in my opinion, the biggest problem has been the accumulation of carbon dioxide. And that is probably the trickiest thing to handle. And I think now the understanding of keeping your pressures low and also playing around, the biggest thing I've difficulty is playing around with the tidal volumes, respiratory rates, so that you get your optimal ventilation as well as oxygenation. As far as complications are concerned, as I say, I've had one complication where a vascular injury and one complication where we had pulmonary edema because, as Dr. Krishna so wonderfully explained, you have the down lung and the up lung, and you have as it is, the changes in the physiology, and then you're giving too much fluid, then you can have problems of pulmonary edema. So you've seen it all, but I would really like to stress, I mean, I don't know how many of you and what your experience was. When laparoscopy first came to India in the 80s, I remember the gynecologist used to put a scope in under local and with the hand pump in air. And we actually had 2 deaths. So, it's not just pushing air and doing the procedure. You have to know that there are problems, which is why, I know that there's a repetition in our lectures. Dr. Krishna and I discussed, what are you saying? What am I saying? And we have covered, repeatedly said that we must know the physiology because you can handle it and you must know the key, as Dr. Krishna said, a good surgeon. I had the fortune of working in a academic institution, but that comes with some disadvantages in the sense that you have trainees and the learning curve is very high. And we've had appendicectomies that have taken 6 hours. Am I right, Krishna? They used to bring them in at night so that they wouldn't disturb the OR list. So, there's no advantage to that surgery for a patient. So if you're doing it for children and you have somebody who doesn't know and who's learning, you have to be really quick on it and say, sorry, doc, it's time that you stop, even if he's your best friend. And even if he wants to go on for another 15 minutes. No, the child is your responsibility. And you have to say, no, try it on somebody next time. This child can't tolerate it. So I think the key is that, one, you should know that you should have all the up-to-date equipment so you can deal with these very complex anesthetics and the physiological changes with it. And 2, you must be strong enough. And as Dr. Krishna said, meticulous. There is no rushing here. You can't afford to have a brachial plexus palsy in a baby. So you have to make sure that everything is absolutely meticulously done before you take it. They might get irritated you, but if he's a good surgeon, he will also help you with the details. That's my opinion on it. It's a nightmare, Laparoscopic surgery was never my favorite anesthetic to give. I have to be honest with you.
Thank you, ma'am. Ma'am, do you think sickling should be a part of pre-operative testing, evaluation in pediatric patients? Because many times the small children, they don't show the symptoms that early in age. But then laparoscopic surgery has got all the ingredients which can trigger a sickle crisis. So should it be a part of the pre-operative evaluation?
I personally don't think so. I don't know if anybody else has other opinions, because for one, genetically, we're not seeing so much but I think if you are working in a center where you're getting a lot of patients coming from areas, like for instance, when I was working in Chennai, we used to have plane loads of people coming in from Africa. And so definitely in that setup, yes, we did ask for sickling for all children who were having the procedure. And so I think one has to be aware of the genetic profiles, which are the people who have it's not so common in India. In fact, I personally have never had a child with sickle cell, but I have anesthetized many in both America and in Chennai because of medical tourism. So I think the answer is, I mean, if you're in Pune or Bombay, you will be seeing people from various continents. And so in those situations, yes, I think you will have to have a protocol that maybe that's why this question has come up. So it really depends on the genetic profile of your patients.
Thank you, ma'am. Krishna sir, thank you very much for your lucid talk. Sir, wanted to ask one thing, that we talk a lot about left ventricular ejection fraction, though it is not included in any of the scoring systems. So is there any cutoff point of LV after below which we can say that laparoscopic surgery will not be safe?
In fact, these numbers only help us in making the decisions. Whether be it the ejection fraction value or the basal PaCO2 numbers, they are all numbers. What I would value the most is the functional capacity of the patient. Now, how good is his functional ability? Is he able to climb one flight of stairs, without stopping, without becoming breathless, without needing to take rest, against a number of ejection fraction? If I were given a choice between these two, I would get the information. I would walk with the patient rather also to assess it. That gives more information to me about the cardiorespiratory interaction. Now, no books, no textbooks, no journals. If you scan any of them, every one of them would give you an absolute cutoff number to say below this, no for laparoscopic surgery. Above this, yes for laparoscopic surgery. No. They only tell us, how careful we have to be. So to me, the functional capacity of the patient gives more information in anesthetic management than the absolute number of ejection fraction. The second thing is that when I know the ejection fraction is low, so suppose I say 35% and above, okay, it is fine with precautions, I can go ahead. 35% and less, I'll have to take into several other things into consideration. How much time would my surgeon take to complete the surgery? With how less intra-abdominal pressure is he comfortable to operate? So all these things will come into the picture. So probably any ejection fraction above 40% in the reasonable surgical hands would be fine with the anesthetic techniques and the monitoring techniques that we have. When we are dealing with an ejection fraction less than that, we need to take into consideration other factors also when we make the decision. There is no absolute cutoff point for that.
Sir, is invasive monitoring a must in cardiac patients?
Once again, it depends on the severity of the cardiac illness. So if the cardiac illness is severe and we think that the compensatory functions of the patients are compromised, that's when we need to be more vigilant in the monitoring. It would help us to have invasive monitoring, like intra-arterial pressure monitoring, beat to beat monitoring of the blood pressure, rather than monitor the blood pressure once every 5 minutes. Now, the role of central venous pressure also would be debatable with the elevated intra-abdominal pressure. We don't know how much of that
elevated intra-abdominal pressure gets transmitted and is reflected in the central venous pressure. But a trend of the central venous pressure, again, is what we are looking at rather than the absolute number of central venous pressure. So if facilities are available and there is a severe cardiovascular disease, it's always helpful to have invasive cardiovascular monitoring.
Thanks, sir.
Can I make a comment? Sorry.
Yes, ma'am. Yes, ma'am.
No,
Yes,
I
ma'am.
see a question here. I think Dr. Pawar has asked, what are the basic investigations you'd advise for all children? I think, it really depends on the situation, sir. For instance, if I have a 3 or 4-year-old boy coming for a inguinal hernia repair, I might just want a CBC. I may not want anything else. Whereas it will be very different if I'm doing a neonate. If I'm doing a neonate, I might, besides, and it depends on what the problem the neonate has. I mean, is it a pyloric stenosis, or is it a TEF? Depending on that, you would have to be more invasive, and usually the neonatologist will deal with that too, whether that's electrolytes or whatever. But in addition, I would probably also want to have an echo if I was dealing with a neonate, because it's very difficult in a neonate to know whether you are or are not dealing with a congenital heart disease. In an older child, it becomes much more apparent. So unless I have a doubt, I would not do a routine echo. But yes, for laparoscopic surgery, and if it's in any neonate, I mean, usually they have a bedside echo in most neonatology units. And if you're in a hospital that has it, then yes. Otherwise, again, it depends on the situation, depends on the disease, depends if it's a urological procedure, you would then go more detailed into wanting renal parameters, liver parameters, you name it. Sickle cell testing, you'd want to might have, if it's a tumor, you might want to see the CT scan. But as an anesthesiologist, and I don't even know when you would insist on having an X-ray, unless, say, it was a child with the T fistula and you're suspecting aspiration. So it really depends on the procedure, sir. And I wouldn't say standard, you have to do renal functions, etc. for everybody. I don't know if that answers your question.
Thank you, ma'am. I can see one question in the chat box for Krishnan, sir. Sir, do you use magnesium in laparoscopies?
Routinely, we don't use. If this question is in relation to hyperreactive airway disease, whether it's like COPD or bronchial asthma, it's not my routine practice to use magnesium sulfate as a prophylaxis against bronchospasm in these patients. My practice is to use this as a last resort when the bronchospasm is not getting resolved with the usual conventional bronchodilator therapy. But I know that there are centers which believe a lot in the use of magnesium sulfate as a prophylaxis because of its membrane stabilizing properties. So they would rather give 1 gram of magnesium right in the beginning and try to get the advantage of this membrane stabilizing property of magnesium in the perioperative period. Why I don't use routinely for all the patients is my concern of the interaction of magnesium sulfate with the muscle relaxant. As Elsa Madam very rightly emphasized the need of good muscle relaxation. We keep criticizing, making fun of the surgeons, but that's the need of the surgery. So because of this interaction between magnesium sulfate and the non-depolarizing muscle relaxant, I don't use it routinely in all the patients with hyperreactive airway disease.
Thank you, sir. Sir, if a pregnant patient is to undergo laparoscopy, what will be better, general anesthesia or regional?
Yes. If we are talking of a surgery in the 2nd trimester of pregnancy, okay, so it again depends on the type of the surgery. Now, suppose if it is a laparoscopic appendicectomy in the hands of a good surgeon, the laparoscopic procedure is good or probably better than the open procedure. But if somebody has not done the laparoscopic procedure on a pregnant lady at all, and he is venturing for that, I would rather say no, you please go ahead with the open procedure. this is not the case to do the first case on the pregnant lady, because there are some specific special concerns with regards to pregnancy when laparoscopic surgery are there. We never insert the trocar blindly in a pregnant lady. It's always a mini laparotomy, open up the peritoneum and then insert that. So all these things, even the location of the structures and anatomical structures are varied in the pregnancy. So unless the surgeon is good at that, we should not be proceeding ahead with the laparoscopic surgery. As regards to anesthetic concern, actually, there are not much difference or major concerns. It's as good as managing for an open surgery. The anesthetic concerns would remain the same. It's the concern with respect to the mother, it's the concern with respect to the fetus, the monitoring of both. So per se, from anesthetic point of view, there's not much, but from surgical point of view, it's going to make a very big difference.
Thank you, sir. Sir, a patient of COPD, if undergoing lap surgery under regional anesthesia and complains of shoulder pain, we sedate the patient and it becomes difficult for the patient to maintain oxygenation. So in those circumstances, what we can do?
Well, per se, I admit that we don't do laparoscopic cholecystectomies under regional anesthesia. So were you speaking of laparoscopic cholecystectomy or lower abdominal laparoscopic?
Sir, even in lower abdomen, even in lower abdominal surgeries, if it is under regional, you can have shoulder pain.
So if the patient is complaining of the shoulder tip pain and we try to give some sedation, some supplementary analgesics, and with that also it is not resolving, the things that we could try is, letting off of some of the pneumoperitoneum, bring down the intra-abdominal pressure, so that what is stretching the diaphragm and irritating the diaphragm, if we can reduce that stimulus, the intensity of that stimulus, there could be a better patient comfort. That's one thing. Second one is the patient position. We know that the gas, by virtue of its properties, ascends up. So if we have positioned the patient such that, it's sort of a reverse Trendelenburg position, and the gas has all accumulated up just below the diaphragm, we can just try reducing that position, neutralizing to some extent, so that the gas moves away from the diaphragm and that discomfort comes down. So these are two things which can be tried despite sedating and giving supplementary analgesics.
Thank you, sir. I can't see any other question. So I would like to thank Varghese ma'am and Krishna sir for your precious time and your valuable input. And I think we all are much empowered now to deal with the difficult situations that may arise in the course of laparoscopic surgery. So with this, I hand over the mic to Dr. Deepak Madankar, ISA Honorary Secretary, to propose a formal vote of thanks.
Thank you, madam. It was our pleasure.
Thank you.
Yes, I would say the same, and I really is an honor to have been invited. Thank you.
Thank you, Dr. Gauri, and good afternoon, everyone. Esteemed faculties for today's program, Dr. Krishna sir and Dr. Elsa madam, Professor and Head Department of Anesthesiology, NKP Salve Institute of Medical Sciences, Dr. Anjali Bhure ma'am, GC member MSc ISA, Dr. Shubhda Deshmukh, and advisory member MSc ISA, Dr. Charuta Gadkari madam, respected seniors and dear friends. With great pleasure and privilege, I propose today's vote of thanks. At the outset, I would like to thank faculty for today's program, Dr. Krishna sir and Dr. Elsa ma'am, for their excellent and enlightening talk for all of us. I am sure we all will be immensely benefited by today's program. I'm grateful to Dr. Anjali Bhure ma'am and the Department of Anesthesia, NKP Salve Institute of Medical Sciences and Research Center, and Lata Mangeshkar Hospital for being partner in today's program, in organization of the today's program. Thank you, Dr. Anjali Bhure ma'am and Dr. Ketki Marotkar for all the help. I'm grateful to Dr. Gauri Arora for being MOC and conduction of the today's program in an excellent way. I'm thankful to MSc ISA for allowing us to use their Zoom platform for the today's CME. Audience is the heart of any program. I'm thankful to all those who joined today and participated actively to make this program a huge success. I'm thankful to the team of ISA NCB 2021 for always being a support. Thank you all.
Right. Thank you very much.
Great, ma'am. Thank you, sir. Krishna sir, thank you.
Yeah, thank you for giving me the honor to be there with Dr. Krishna, because I had the pleasure of working with him for many decades, I think, Krishna. And it's very nice to be on the same platform as him. Thank you.
We had the honor of hosting you of both.
Yes, absolutely.
Greater honor than.
Okay, all the best, and thank you once again.
Thank you, ma'am. Thank you.
Enjoy the rest of your Sunday. Thank you.
Thank you. So we'll conclude.
Yes.
Thank you.